Medical information on this site is provided as an information resource only and is not to be used or relied on for any diagnostic or treatment purposes. This information does not create any patient-physician relationship and should not be used as a substitute for professional diagnosis and treatment. Please consult your healthcare provider before making any healthcare decisions or for guidance about a specific medical condition. Doctors Ruhoy and Kaufman shall have no liability for any damages, loss, injury, or liability whatsoever suffered as a result of your reliance on the information contained in this site.
Hi, this is Paulo. I'm introducing us right now, but we're going to put you on the microphone in just a second because you can hang on. Hi, this is Eileen Ruhoy, and I'm with my co-host
David Kaufman. Hi.
And this is another episode of Unraveled: Understanding Complex Illness, and we have a special guest on the phone. So this is Dr. Paulo Bolognese, neurosurgeon extraordinaire. You want to say hello to our fans?
I say hi to everybody.
Hey, Paulo.
Hi, David.
Do you want to say just a few pearls before we let you go on about your day, doing much more important stuff than this? A few pearls about anything? CCI, EDS, anything you want to say?
The first pearl is about the podcast itself. It's a great idea, and for what I've seen and heard so far, and is also very well executed. And it was about time that there was some, poised and detailed and nuanced information about all these problems, spelled out and offered to the community. So this is a very good thing because there is a lot of information out there, but it's not very well organized. Sometimes it's confused, sometimes it's refried beans, and this is the first time that I heard it in such a way that even I understood it, and I liked it very much so far.
Well, thank you for saying that. That's what we try to do. We try to sort of dissect things and put it into simple terms for patients and even for doctors who haven't yet worked in this kind of space and are trying to learn more for themselves so that they can better help patients. So we appreciate that, Dr. Bolognese. Oh, my husband's calling me now.
We're going to have to get you on camera soon.
Yeah,
Paula.
we're going to get you on camera. We're going to have lots of fancy technology soon in our new space. So we're going to get you on camera soon to be a real guest. Okay?
Oh, very good.
All right. Well, have a great day, and I know we will talk again soon.
Very good.
Okay. Bye.
That was not a paid advertisement. Very
it was
spontaneous.
Not. In fact, it was unexpected.
He called just before we were about to record.
So welcome to, we're actually in a new space, and I think you could see we have a different environment because it looks a different room.
Yeah.
So we're really excited about our upgrade, which we think this will be, and we have lots of great plans for the continued success of our podcast. And today we have a really interesting topic that was sort of born out of one of my neurology journals, specifically the Movement Disorder Journal, which talked about the endotoxin hypothesis of Parkinson's disease. And, I usually read a lot of these articles and I look for tidbits that sort of connect in ways of what we see in our patients and things that we know about chronic illness. And I often say that I connect some pieces of a puzzle from different specialties, but obviously mostly my own. Okay. And this one, I was so excited about it, I sent it to you. This one was so on target of what we talk about, of what we think about when we think about diseases like ME/CFS and like long COVID and everything else, and the septad patient, that I just felt like we just really need to tackle this. And it's the endotoxin hypothesis, which I admit you know a lot more of in terms of an endotoxin and bacterial infections. And so I feel like it's a perfect topic for you and I to discuss.
It's perfect. And before we dive into it, one of my reactions is, like you, I read constantly. I mean, to a fault, okay? Papers that I find on my own, papers that are referenced, sent to me by patients, a lot of papers from patients, papers from masterminds. Just a lot of reading.
Yeah.
And every once in a while, maybe once every 10 days, which is pretty good actually, I'll read something that just gets me crazy excited. Mm-hmm. It's like, oh my God, it all connects. That's that. It all works. Long COVID, ME/CFS, septad. So that's this paper. I went nuts when I read this paper.
Yeah, it was a great paper and
great.
So well written. And I will say for a really long time, we understood that or at least we believed that Parkinson's had some etiology within the gut, because I mean, the vast majority of Parkinson's patients have a long history of constipation. And I know constipation is like, everyone's got constipation to some
but
extent.
I didn't know. I'm not a neurologist.
Right.
50% of PD patients have constipation.
At least,
That is mind-boggling
Yeah.
if you now think what I rant and rave about with SIBO.
Absolutely. Absolutely. And then we also thought it was, we really long believed that it had to do with some exposure. In fact, there's been a lot of articles with regards to environmental exposure, so contaminants, intoxicants, and there's been a lot of research to support that. And oftentimes with a Parkinson's patients, I'll take a long exposure history for that reason. And I've actually had lots of Parkinson's patients that have had, occupations that were on, in the agricultural world, or actually, living here in Seattle, I've had several that have worked at, Boeing, SeaTac Airport.
Right, sure.
And
sure.
So exposure for sure. But, this idea of infection just sort of being the root of it all, and then maybe other exposures just laying upon this, and the whole lipopolysaccharide hypothesis, and what it does, and how it's transmitted from the gut to the brain, and how it can promote for synuclein development and then synuclein aggregation, and then transmit it via the vagus nerve. It just brought it all full circle for me.
Right.
So
and to be clear, it's not in this paper at any rate. It's not that infection. I want to make sure listeners, readers, listeners, whatever you are, subscribers,
listeners and viewers,
understand. We're not saying it's an organism infecting the brain causing Parkinson's disease. That's
so let's start there. So what is LPS?
Okay, so it is a component of gram-negative bacterial cell walls, and we are filled with bacteria in our gut. So there's LPS all the time. The question or the issue is, where is that LPS? Okay, and so evolution, once again, over millions of years, we evolved a gut that is designed, in quotes, to keep the LPS in the gut, i.e. tight junctions, so there's no leaky gut. As soon as you begin to have a leaky gut, the LPS can leak across into the blood, and that's when the trouble starts. There may always be some leakage. The paper makes reference to there's always a little bit of LPS.
Right.
But I think people need to understand how profoundly powerful LPS is. It is an endotoxin. It is used in the laboratories, in medical and science research laboratories, to mimic sepsis, which is what people die from in the hospital. That's how potent it is. So in large doses, so to speak, it causes drops in blood pressure, high heart rates, coma, multi-organ failure, okay? So we're not getting it in those doses. It's just leaking across in these little bits, all right? And then the paper begins to address it. Well, what does that mean, and what does it lead to? And that's where you start connecting the dots.
It's amazing. So the fact that even low levels of endotoxin can promote what we know to be basically largely, in fact, it talked about how it can provoke the innate immune system, and that brings us back to the mast cell and the mast cell activation syndrome, and this chronic inflammatory response that just sort of simmers and builds and grows to now where there's pathology that, maybe now it's too late to really sort of turn back the hands of time. But the idea that we could consider, if there's any kind of gut alteration, so like SIBO and leaky gut, constipation, gastroparesis, that this could be a marker of something that is, scary to come, and we can treat it early, gives us so much greater chance at really managing and preventing further illness for our patients.
I mean, one of my, I don't want to say conclusion, one of my thoughts was, if you read this and you think about it, we all have bacteria in our gut. We all have a microbiome, otherwise we'd be dead, extinct as a species, right? And the assumption is that there's a degree of leakage, and then the second assumption is that pathologically, if that leakage increases for whatever reason, the person may run into trouble, and we should go through that in a minute. So maybe we don't wait. It's maybe, like you say, it may be too late to do anything if somebody presents with some phenotypic presentation of Parkinson's, but maybe we assume to some degree that everybody's at risk for this in our modern day world, which is filled with toxins and pollutants and bowel dysfunction because we don't eat enough fiber and everything else. Let's just assume everyone's at risk for leaky gut.
That's true.
Maybe not even bother doing SIBO testing anymore.
Right.
I can't believe I'm saying that. And then are there ways to preempt the problem? Are there harmless risk-free things we could do to preempt and prevent? Because whenever we talk about prevention, an intervention to prevent something, it has to have near zero risk because you don't know, you're going to give it to everybody, so to speak. And so you don't want to cause a risk for somebody who might not have had a problem in the first place. Is that
of course,
okay,
yeah.
Right. So the first thing that came to my mind, we're getting way ahead of ourselves here, is something like butyrate. Butyrate is a short-chain fatty acid. It promotes a healthy microbiome. It promotes tight junction healing. It promotes better immunology in the gut, where 70% of our immune system resides. And it's just those 2 stinky smelling pills a day. You know, it's like such a no-brainer.
It is such a no-brainer, but I have to ask, like, so, I mean, dietary interventions, and I know that no one really wants to talk about dietary interventions because it seems like such, you know, the internet is filled with like what diet is appropriate, but I can't help but think that if somehow we all agree upon what, you know, the appropriate diet is for a human body, and we all just sort of stuck to that, that somehow we would be better protected from things that would otherwise attack our gut lining and create excessive permeability and leaky gut and all this other neurodegenerative risk, right? I mean, do you agree with that?
Well, I agree, but how are we going to know what that diet is? How are we going to get everybody to agree?
Well, this is a whole other topic that we should tackle one day. You know about me, and I know about you. We are proponents of a plant-based diet.
Right.
And I have been more raw recently than before, but I've been a vegan most of my life. I really do believe that the earth has what humans need. And I think that we are herbivores. I don't think that we're omnivores. You know, so I think, and I'm not saying that everyone agrees with me because I know not everyone does. But I do think that if we can at least come to some level of consensus as to what humans are meant to eat, or at least meant not to eat, maybe that's a better question to answer, then I do think then our gut is better protected and not as, and I realize that, you know, I often get, well, I can't tolerate, you know, broccoli or, you know, or some of the high histamine foods, right? Because there are some vegetables that have high histamines. But I think that that's more of a consequence of previous poor dietary choices than of you know, the idea that, you know, humans aren't meant to eat those kind of plant-based foods. And again, I am getting off topic, of course, but I can't help but think that somehow if we all had healthier diets than the standard American diet, which I think we can all agree on, that somehow we would at least decrease the risk that much more.
Yeah, I mean, I 100% agree. I'm just a little bit more cynical that I don't know how we're going to get there. We can't even agree on. I can't even say all the things because I don't want to get into politics, but we can't agree on anything. Okay, so my approach would be a little bit different.
Got it. The butyrate.
What butyrate? And in terms of diet, what are the ways? So what's the issue? The issue is the healthy microbiome and a healthy gut motility. Okay, so I think everybody would agree that motility is dependent to a significant degree on fiber. Everybody knows Americans don't eat enough fiber.
Right.
That's why everybody's constipated. And that leads to decreased motility, and that lets those little bugs in the colon swim upstream to the small bowel, cause injury to the gut, make it leaky in the colon too, but especially in the small intestine. And then the cascade starts. The game is on.
Right.
So yes, I'd love to get everybody to agree, but I think it's easier to get them to just have more fiber.
I agree with that. I also think that once you're sort of in the throes of even just, let's say, you know, early on basic constipation, it's actually really hard to just now change your diet and correct all of that. I mean, I have a lot of patients ask me if they should take laxatives and things like that, but I think once things are impacted, like just adding on top of it, is including fiber, by the way.
No, then you have to treat that.
Right, you have to, exactly.
Right.
So it's right. So I guess I'm talking more of a preventative approach that has to start at a very young age, and that's not going to happen. So let's just move on. But we do have a lot of ways of treating SIBO and leaky gut. I mean, there's a lot of tools in our arsenal to address that, and certainly there's a lot of tools in our arsenal to address constipation. And I've taken on constipation, I think, more than any other neurologist has, just because of my patient population. And I've had to learn about. I've gone as far as using like octreotide and low dose erythromycin, and some of the other pro-motility drugs out there, and so I've gone beyond the Senna and Miralax and
no, I agree.
And they are helpful, and it's nice to sort of get things moving, because that is the first step, right? If you get things moving a little bit, there's no stagnation of waste products, and therefore there's less alteration of the microbiome, and then less risk of this endotoxin buildup, which then can create more of a leaky gut, more permeability, enter the bloodstream, and then enter the central nervous system either via the enteric neurons or the vagus nerve. Or other peripheral nerves, but which I find this fascinating, because we've always talked about this access and this interconnection between the gut and the brain, and it's long been understood. In fact, a lot of autoimmune disorders have been noted to have a root from the gut, and which in terms of its interaction with the central nervous system. And so the idea that neurodegeneration can be found in this root as well, I think is really it's just so powerful to me, because it is such a perfect place to start treatment, because all these patients suffer from some level of gut.
It's not difficult.
It's not difficult, right? Which is nice.
Just let's get it back to the LPS itself. Just sort of see if we can walk it through. And I don't pretend to understand all of it. Okay, the paper elegantly describes it, but.
It's called the Endotoxin Hypothesis on Parkinson's disease, by the way, and it's a movement disorder journal. And I believe it was the July or the August. It was very recent.
I think if you just Google endotoxin Parkinson's, it'll probably come right up.
It does, yeah.
So the LPS leaks across the gut. As I said, it's a very immunogenic. It stimulates the immune system.
Specifically the innate immune system, which was, again, the mast cells, right?
So, and then that signals the mast cells to start looking around for enemies. And that I believe fully, although I don't have proof of it, is a cause for so-called mast cell activation syndrome. It doesn't just come out of the blue. You don't catch it walking into the supermarket, MCAS. It's there for a reason. And yes, I know the science that Larry Afrin talks about, et cetera, but that doesn't really answer, well, why do you have it and I don't, or something like that. Okay. So I think one big reason is leaky gut. LPS comes across, stimulates the innate immune system, kicks off mast cells, and that begins a whole cascade of low-grade, indolent, inflammation that circulates, and ultimately that gets up to the blood-brain barrier, and it does injure that blood-brain barrier and make that leaky as well. And that's like the difference between the enemy crossing the moat and the enemy climbing up the walls and into the castle.
That's right. That's a great analogy, actually.
So it's a big deal, and that begins another cascade in the brain of inflammation. Microglial cells get activated to clean up. You should take over at this point. And they have all this, and that starts to cause trouble. And I suspect, and this paper kind of kicks it off, it's not just PD. It's probably related to Alzheimer's and dementia.
That's where I was going
small
with
vessel
this.
Disease in the brain.
That's exactly where I was going to go with this towards,
trillions of dollars or billions of dollars have spent on tau protein and amyloid and plaques.
That's right. But it's not just synuclein. This paper obviously focuses on synuclein because it's a movement disorder journal. Parkinson's disease is the most common movement disorder. It's a synucleinopathy, so it focused on the synuclein protein. But there are other proteins that are abnormal and abnormally accumulate and aggregate that cause other neurodegenerative disorders, Alzheimer's being one of them, as well as a lot of different. There's like synucleinopathies and tauopathies and things that also have abnormal aggregation of amyloids. So all of these proteins are at risk, is what we're saying, basically, from this neuroinflammatory response to this LPS and So endotoxin and LPS, they're not interchangeable, right?
They are. They say that in the paper. They just use they say some people say endotoxin, some say LPS. We're just going to stick with LPS. No, they weren't. They're saying they're synonymous. They are synonymous. Although I think in the infectious disease medical literature and the intensive care literature, you'll say endotoxin because they're septic and dying.
And it's specifically for gram-negative bacterium.
as far as I recall, it's only in gram-negative bacterial wall. Yeah.
Okay, and we do have gram-negative bacteria of our normal microbiome.
Of course.
So we always have low levels of LPS.
Right. And as they point out, we also have it in our mouth,
in our mouth,
in our
right.
gums, and there's an association that they describe between gingivitis and Parkinson's disease for the same reason.
Absolutely, exactly.
Reason.
The other
so exciting. I just love it.
Other interesting thing that came out recently, though, I didn't find the article, but I saw a little snippet. Neurologists, we get like little alerts of like new stuff that's being printed and published, is that another risk factor for Parkinson's is allergic rhinitis. And I thought, this is so interesting because I had just read the Endotoxin Hypothesis and I was thinking about the mast cell activation. And now here we have another piece of the puzzle, right, where patients with allergic rhinitis, which you can argue is a mast cell kind of response, is another risk factor that a majority of Parkinson's patients have a history of allergic rhinitis.
Right. And then one can speculate further connections of the dots, okay? Mm-hmm. People get COVID, and then 30%, give or take, get long COVID. Mm-hmm. Why might that be? Now, we're not saying viral particles have LPS. They don't. But they infect the nose. They infect the mouth. They often will lead to, or may often lead to, secondary bacterial infections, and then you're back on that cascade.
That's right. And so whereas I would try often to downplay the role of mast cells, because I kept thinking, how could this all be related to just one species of a cell? I don't even know if species is the right word, but one lineage of a cell. Really, I think that the innate immune system cells have not been given due credit, specifically the mast cells, but probably some of the others, right? Yeah. We've always talked about autoimmunity and the adaptive component of the immune system. We haven't really focused enough, I think, on the role that the innate immune system plays in causing disease. We focused on it about how they save us, they keep us alive, right? They're our first responders, as we say all the time, but how they actually can contribute to disease.
Sure.
Sure.
I mean, again, in that paper, they reference the role of monocytes as carriers or causes of inflammation.
Right.
That's really important.
It's incredibly important. And so, kudos to Larry Afrin.
So it's an interesting, there's a quick side note, okay? And, we've talked about valganciclovir, Valcyte, which is an antiviral, very potent antiviral for CMV, HHV6, and EBV. Right. And in the original, one of the early papers done at Stanford with Montoya, where they showed elevations of HHV6 serology, symptoms, and then when you took Valcyte and the serology improved, the patient's symptoms improved. But one of the other findings, which is so interesting, is that also when you take Valcyte, your monocytes decrease below normal. And that may be a potential connection with the other action of Valcyte, which is working as an anti-inflammatory in the brain, which is why it can help brain fog patients. So it's, all these things start to come together.
They really do, actually. And, even with the antibiotics, that I would see these patients with, I have hair, it's like tickling my nose, I'm sorry. But, there was so much, like take autoimmune encephalopathy or take even Lyme disease or any of the tick-borne illnesses. And these patients are on lots of antibiotics and they would have improvements in some of their neuroinflammatory symptoms. And I would think, but they'd been on it for years. And so I would often think that there's an anti-inflammatory component to all of these drugs, including the antivirals that we've long known about. And so I think that we also don't give enough credit to that anti-inflammatory component and not only are they antimicrobial, but they're anti-inflammatory. And I think that, again, that's why those drugs are important. But what's interesting about, of course, antibiotics, and I know you were talking about antivirals, but it made me think about something else with regards to the paper, was that, the more antibiotics you use, the more you change that microbiome, right? The more you open it up to unhealthy flora or unhealthy populations of species.
But they can help the microbiome too.
But they can help the microbiome. So it's right. So this is sort of where we get stuck as clinicians, right? Like you don't want to do any harm. You only want to do good. So you have to sort of weigh and balance what you're doing for patients, right? And it's like you have to make sure. Yeah, that's why you have to check in with patients a lot, because you want to make sure that you need to tweak it when it needs to be tweaked, or leave it alone when it doesn't need to be tweaked. And I think it's a very hard balance. And I think everyone has their own balance, right? So like in terms of a patient, in terms of response to things.
Again, the exciting thing about the paper is, obviously this connection between gut and brain, and that's not new, but in the world of medicine and science, it is new. I mean, that's a connection that's only being discussed and researched.
That's absolutely true.
Maybe in the last 10 years or 15 years, and I think it will just end up explaining so many things.
I think it already does. I think the problem is that and we're going back to sort of our swan song here, which is that to get specialists, specifically, let's take Parkinson's disease, which is what the paper was on, to get the specialists to actually now sit back and think about how they're going to treat a patient's gut, they're
going to refer it.
They're going to refer it, right? So now you get a gastroenterologist, presuming,
right,
who's going to get a Parkinson's patient.
And I'm sorry.
And this is where the silo of medicine goes wrong.
Doctor audience, I've never yet met, except for one person in Masterminds, a gastroenterologist who actually treats leaky gut.
Right.
They all give Xifaxan automatically, reflex reaction, which it should be if they have SIBO. They don't treat leaky gut. It's kind of
how do you
one
treat
and
leaky
done.
gut?
How do I treat it?
Yeah, how do you treat it?
Each day it gets more complicated.
That's what I thought, because you once told me, and then I had a patient of yours recently, and I said, well, how are you being treated with your leaky gut? And it was a wholly different regimen.
Yeah. So I use supplements which are supposed to help heal give fuel to the gut, like you use for mitochondria, to the gut, the mucosal cells. Oral gamma globulin to help increase the kill of the bacteria and prevent recurrence. Butyrate, curcumin to reduce inflammation in the gut. I can't believe I'm slow on this. BPC 157.
Oh, I love BPC 157. The oral form.
Yeah, oral form. I know I'm forgetting something else. I write this so many times a week, I can't believe I'm forgetting.
You probably have a chart.
I have a template. I have a chart part, right? And I'm not done.
Yeah. No, I know.
The truth is, every time I read a paper like that, have a conversation like this, or listen to a podcast, I think, I should add that.
Yeah, so do I.
So actually, that's a good segue for me to go back to the brain stuff.
Oh, sorry.
No. So the LPS does all these things, and then there's either downstream or collateral damage. And today, I made a mistake and got here 2.5 hours early. I was listening to a podcast on the blood-brain barrier. And part of the discussion was how, as the injuries start to occur, the glucose transporter gets damaged.
The GLUT4 specifically.
GLUT4. So now you have a decreased transport of glucose into the brain. Brain lives on glucose. I think it's 20% of the glucose is used in the brain, right? Damage to the free fatty acid transport system, which is, omega-3s, which are crucial. And you just begin to see how the LPS is like a stone thrown into a pond, and it just ripples out, and it's bigger and bigger and bigger.
So well put. So well put. Good job. No, it's true. And also, the blood-brain barrier, just by its nature of its, the pericytes and the astrocytes, there's mast cells that sit along the lines there. And in fact, I did a recent TikTok, and I talked about mast cell and the blood-brain barrier and how it could become basically permeable. I don't like the word leaky to the blood-brain barrier.
I didn't like it before, but I use it now. I don't care. I didn't like it for the gut either, but
just from some of the mediators of the again, all those inflammatory mediators, and so so there's a ton of, there's a million layers to this that just all really put everything into a clear picture when we see patients, right? And it does give ideas in terms of how to treat, for sure.
Right.
So, and again, with the decreased glucose uptake, the dysregulation and dysmetabolism of glucose that happens, and then the defunct fatty acid cycle, there's basically no energy for the brain.
Right. So the more we think about a paper like this and we talk about it, the more connections you can make and the more speculations you can speculate on and the more possible interventions. So this paper was referring specifically and exclusively pretty much to Parkinson's disease. But clearly my argument, your argument, is that this may well participate as a cause for ME/CFS and long COVID. The literature on HIV disease and progression to AIDS and leaky gut is huge. That was one of the things that was discovered reasonably early once they could identify HIV, that it injured the gut wall and made it leaky. The viral organism shanghaied the gut immune system and made it leaky and took over. I mean, it's incredible how it all gets connected. There's another paper, I think one of the authors is Mays, M-A-E-S, that I read 7 years ago, which basically is leaky gut and ME/CFS. So it's not new, but this paper just reignites it for me.
Right, but ME/CFS, I think, well, less so, is a little bit more of a controversial diagnosis,
Yes,
right? So
right. Whereas PD
certainly
is
less
not.
so than 7 years ago,
Right.
I think.
Yeah,
I mean,
you're right.
Yeah,
You're right.
but still controversial in many circles. But Parkinson's obviously not a controversial diagnosis. I think there's some controversy with regards to what really is the cause. There are some familial components, but clearly most are not familial, most are not hereditary. There have been some genes that have been identified that seem to put you at risk for. But again, we have long understood that there seems to be some environmental component to this, some exposure component. We've talked about, in past research, the role of the mitochondria. We've talked about, like I said, environmental toxicants and contaminants. And then other neurodegenerative disorders like MS and Alzheimer's have had recent research with regards to a viral etiology, which is, also exciting in terms of treatment options early on. As we know with most diseases, the earlier you treat, the better that the patient could potentially be. That's why I think long COVID is so interesting, because I think we're seeing ME/CFS at an earlier stage.
Absolutely.
So it's
Long COVID is like a MECF model
totally
in the works.
Exactly. So I think that, if we just take Parkinson's if we just sort of refer to it as a neurodegenerative disorder, which it is, of course, but if we apply what this paper sort of talked about in terms of what they have found in Parkinson's patients and apply to other neurodegenerative disorders, of which I think all of these fatiguing illnesses technically are, I think it really gives us great insight, a new window of understanding. It doesn't immediately change what I've already been doing for patients, and certainly what you've already been doing for patients, but it gives it more almost like urgency, like I've been trying to fix your gut, now I really want to fix your gut, kind of thing.
Well, and I think it opens up the opportunity to speculate further and experiment with interventions that feel relatively risk-free, that may have benefit. And let's spend a few minutes on that, okay? Mm-hmm. And obviously, I'm not telling people to go out and do these things, but reading that paper and listening to this podcast, so this is all at once, all right? Clearly, I'm not telling patients to take enough omega-3s, okay?
Right.
I'm convinced of it now. Yeah. I'm absolutely convinced. I've listened to 2 podcasts recently, read the literature of the podcast discussant, the person they interview, go back to their research. And it's just clear, we undertreat. We have low omega-3s, and we should treat it. There's almost no downside, and it may help blood-brain barrier, leaky gut, red blood cell health. I mean, so many things. Okay, so that's one. Second is the butyrate. All right. The third is metformin. So we've mentioned metformin off and on a little bit. And a lot of our patients know about metformin in the world of long COVID and in the anti-aging world. And in this paper, they reference metformin, saying it can alter the microbiome and reduce the leaky gut, and that may be another reason it helps. And oh, by the way, why do diabetics who should have a higher mortality rate live longer than non-diabetics if the diabetics on metformin? Right? It's like, how do you argue that conclusion?
I wonder where the new semi-glutides are going to come in.
Well, I think they're just starting to understand.
Yeah, I agree.
Just starting.
Right, because, I mean, that's just a whole interesting class of medications now that I know has been, exploited for weight loss, but I think that there might be some other potentially great benefits for them, for patients with chronic illness. But I guess we'll have to wait and see. But I agree. I've also realized that I'm not being aggressive enough in treating these things. I've been treating them, but not. And I think I think in our defense, it's because there's so much information that you sort of want to try to cover everything.
Well, we don't really know.
But
look at probiotics. Look at probiotics.
Yeah.
You can't wake up in the morning without hearing about probiotics. But we don't know shit about that. We don't know.
We don't know.
We don't know which one should you take for Parkinson's. Should you take this one for Parkinson's and this one for dementia and maybe this one for Crohn's disease? We don't really know. And so we're dumping that in. And meanwhile, we're sitting at the same time saying we have a microbiome that's dysbiotic, it's not healthy, and it's causing a leaky gut. Well, maybe the probiotics that we're giving that person are
Right.
doing that.
And we've said this before in our conversations that I don't even know what a healthy microbiome is for any individual.
Right.
I mean, we know what unhealthy species are. We know you shouldn't have
Yeah, there are
too much of
studies
this
out there, sure.
population. But a lot of your microbiome depends upon a lot of different variables, like where you were born, how you were born, what you were fed early in life, where you lived, what your exposures were,
Right.
what kind of food did you eat, what your lifestyle, what your stress levels were. And so for everyone, there's some, variability, and it's not going to be a cookie cutter, like everyone should have this microbiome.
Exactly.
And so it becomes very difficult to manage, like you now have a healthy microbiome. And I think when I started to wonder even the role of fecal transplants, actually, when I was reading this paper, which I know you can't get in this country unless you have a diagnosis of C. diff, and I'm not sure if that's still even the case, but that was what I learned 2 years ago. And I have patients who are flying out to other countries to get fecal transplants, and then someone recently told me that you can buy these pills off the internet, and I'm like, that doesn't sound right to me, but so I can't advocate for that. But I do wonder the role of a fecal transplant at some point. I remember reading studies actually that they took like someone who was overweight and someone who wasn't, and then transferred like the person of normal weight to the person who was overweight, and that person who was overweight lost weight just from the fecal transplant. So there was clearly some microbiome related association to BMI, basically. Right. So there's a lot, I think, that needs to be explored that we just haven't explored.
Yeah, I think what you just said and just before that about microbiome is just so true. We don't really know.
Yeah.
But I would put this out, okay?
Okay.
It's back to evolution. Right? We've been around for let's call it 100,000 years. I mean, obviously it's millions, but in terms of human beings, okay? Up until 200 years ago, 250 years ago, there were no antibiotics. Life was very hard. People starved. Mm-hmm. They got sick. They died. I mean, life was way harder than our life. And yet you don't hear about so many of these diseases in those times. The whole world of neurodegenerative diseases, the diseases of aging, are a product of modern times. Yes, that may be because we live longer because of the amazing accomplishments with infection control. I understand that. But I would also argue that the difference from an evolutionary point of view is we live in this unbelievably polluted, toxic world. We eat garbage. Eating raw is better, eating vegan is better, eating plant-based is better, but at the end of the day, it's so hard to find food products that are not contaminated in some way, either with hormones or pollutants or fertilizers or pesticides.
It's also not that accessible for everyone, right? I mean, so even if someone has intent to try to eat healthier and well, sometimes it's not accessible in terms of where they live. Right. There's a socioeconomic argument to be made. I agree, and I think our food supply, by the way, is not only contaminated as well. Even those that seem to be of a healthier sort, but it's also just not. It's even devoid of the nutritional value that it had 100 years ago.
Yeah, and again, it's also related to pollution and stuff in the air, smoke, and one of the things I heard today on this podcast was. An autopsy study, this was a horrible autopsy study of babies in Mexico City, and their brains already had some plaque development. We're talking about babies,
I'm not surprised. The World Health Organization about 10 years ago did a study and found over 110 contaminants in cord blood.
Right.
So we're already born exposed.
Exactly. And that's such a difference from the past.
It's such a huge difference.
Helps explain, I think, the modern diseases that we are all struggling
Without question, we are so overexposed. And I regularly say that, like our environment is just dirtier and dirtier. And the other thing is, don't forget we're constructing into areas of the planet that I don't think humans were necessarily meant to interact with. So we're being exposed to pathogens that we might not have been exposed to. We might have been more protected from if we had not been deciding that we need to construct some large building or parking lot.
And flip that on its other side, which I think you've heard me give this talk, we're not exposed anymore to pathogens that we evolved with that provided a significant degree of gut health and immune health. And that's another reason we may be having these problems. I mean, that's a whole other conversation.
I think humans are, we're really into evolution now, but I think humans, I think humans are in a state of flux, frankly. I think our environment and human evolution, I think we're sort of at this crossroads, as they say.
Well,
and we're all suffering.
look
And
at
we're all
climate
suffering
change.
at different
We may not
levels.
have to worry about it much longer with climate change. We just may all go extinct.
Oh, my God. So
All right, I don't know what our time is like, but I want to comment on
we're
another
into-
intervention that I got so
Okay,
excited.
sorry, yeah, we
I've been
didn't even
saving it for last. Okay.
Maybe with the next episode, we can do actual interventions on all this.
Low-dose naltrexone.
Low-dose naltrexone.
So we have talked about it. You've all heard us talk about it a lot. LDN, as far as I'm concerned, LDN is the aspirin of ME/CFS and long COVID.
Mm-hmm.
Okay, it's the only drug. It's mostly the only prescription I will give to a new patient on their first visit when I still don't have any laboratory data. That's how good I think it is. Okay. And we've gone over what it does. It improves gut motility.
Mm-hmm.
Check. Okay. It decreases inflammation by modulating the immune system. Check. And that decreases mast cell activation, most likely. It decreases inflammation in the brain at the microglial level. Okay. And one of the mechanisms that it does that, all those things with, or that's involved with LDN function at these low doses, is blocking toll-like receptor number 4.
Oh, that's what
And
the article
that's
talked
in the
about. 2
paper.
and 4.
Exactly.
No, that's right. And that was fascinating
And therefore,
to me. Yes.
Dr. Ruhoy, we need funding to do an LDN prophylaxis trial with patients at risk for Parkinson's disease.
Oh, my God.
It is a fucking no-brainer.
Oh, my God. That is
I got so
true.
excited when I saw that.
That's right, the toll-like receptors,
Yeah.
and it was 2 and 4.
The
That's right.
TLR4 is blocked by LDN, and much of the literature, much of the work, if you look at Jared
Younger.
Jared Younger's work, that's a major mechanism of action for LDN in what it does for us.
I love that idea for a study. I love that idea. We need funding.
I mean, it makes me think I should just start it. Seriously.
I think you
why
should.
Why wouldn't we all take it?
I'm going to start taking it. I prescribe myself all the stuff
I'm already
that we
taking
talk about.
fatty acids and this and that, metformin. Why
My
not?
husband makes fun of like the stuff that I have in the cabinet. He's like, "Are you really taking it?" So I'm like, "I am," because all my patients are. I'm going to take it too.
Right.
But I agree. I mean, I think LDN is magical. But you're right. The toll-like receptor number 4.
Yeah.
It's a great study, actually. And as you know, and we often sort of struggle with how we even interpret some of the things that we do, that some of the workup that we do for patients is on the skin biopsies. I don't uncommonly find synuclein staining, and there have been papers that have associated synuclein with more severe phenotype of POTS and other kinds of autonomic disorders. And that's sort of how I've seen it. I never really knew or even understood if it really proposed any greater risk for developing something like Parkinson's. I don't think it does. Certainly none of the literature would suggest it. But then I read this paper and I'm thinking, well, maybe if I start putting these pieces together, maybe there is a greater risk, but I don't know for sure. And I think that's another, that would be a longitudinal study, of course, so that we would have to, sort of control for lots of different variables. But I think that these things are all really important to have dialogue about. But again, as with all disease states for the most part, the earlier you can treat, the better off patients will be. And the earlier you can think about prevention, the better patients will be. And that's why I think it's important to even think about, just like I said, dietary interventions and stress management and how well you sleep, by the way, which really does control inflammation in other kinds of ways. And, we can talk about that another time. But, lifestyle does play a huge role in prevention.
Exercise.
Moving things like
everything I read and every podcast I listen to, every person I talk to in the science world, the only thing they all agree on, and the literature supports 100%, is the role of exercise in preventing neurodegenerative disease, cardiovascular disease, diabetes, glucose intolerance, insulin resistance, just sweat.
Food, sleep, and exercise. There are a ton of research and they're published even in neurology journals where it shows that, and it doesn't have to be, extensive. Like it doesn't have to be climbing Mount Everest. Right. I mean, in fact, there was a couple of studies that showed, walking 30 minutes a day for 5 days a week is really all you need to lower your risk of things like cognitive impairment and dementia syndromes and such. So it doesn't have to be a lot. And it can just be even removing certain inflammatory foods from your diet as opposed to trying to eat more
Right.
kale.
Right.
So
Sure.
simple things like this can actually have an exponential benefit to lowering your risk of further diseases,
Right.
of diseases further in life.
And I want to. We should acknowledge that we recognize that for our patients with ME/CFS long COVID septet syndrome, or whatever we call it these days, it's not easy to do what we just
No,
said
it's
with
not.
respect to
It's not.
exercise. And I regard one of the biggest challenges is to figure out an exercise mimicker for our patients that
Yeah.
are not yet able to exercise. Meaning, how do we, what's the word is mimetic? How do we get the benefits of exercise in blood flow, mitochondrial health, barrier health, meaning blood-brain barrier health, without trying to get the patient to exercise who's incapable,
Yeah.
but they just can't because
I
of their
agree.
illness.
I've thought
And I
about
think those
that
things
a
are
lot.
out there.
They are out there.
That's the
So
rapamycins of the world and
Right.
stuff.
We should say that nothing will truly take the place of exercise.
Absolutely.
But I do think that we can mimic some of its benefits to some extent. I
Which
think
may then get them healthy enough to start exercising.
that's my goal. That's
Yeah.
always, and I always say that to
Sorry.
patients. Like, my goal is to get you to be able to walk around the block first, right?
Right.
Where without you crashing or having a prolonged recovery. That's my goal. And so, there's a couple of things that we try with medications. Sometimes just some passive movement, like while they're even in bed or sitting in a chair. Some of them have physical therapy who come to their home, to sort of help them do it, to
Right.
sort of keep them safe. And so, I think I even think some of the new modalities, even like the red light therapy, I think provide some blood flow to the skin. Certainly, I love the hyperbaric oxygen, but that can sometimes be hard to access if you have a hard time leaving your house. So I think that there's a lot of things that can be utilized to try to start to mimic the benefits of exercise, just to get them to be able to exercise.
I agree.
Yeah, and that's what we work on.
I've had this. I have this thought that I don't know how to actually find out more, but maybe you know. So in terms of exercise, our patients can't exercise. One of the values of exercise, presumably, is the contractility and relaxation of the muscles. So are you familiar with the vibration platform device that they use in gyms where you stand on it? And
Well, 50 years ago they used them in gyms. I don't think now.
No, they have these things that you...
Still in gyms?
Yeah, there's a name. I can't remember the name.
The vibrating...
Yeah, and it's
plate?
used.
No,
Yeah,
I know.
But would that be a mimetic for full-blown exercise? Could a ME/CFS patient...
No.
Because it would use too much mitochondrial energy, so to speak.
I would say, if a patient asked me, I would say no. And the reason why is because I'd be worried about their connective tissue. I've been on those things. Those things can be harsh.
Right.
I have to hang on for dear life. I hear what you're saying, and it's a good thought, but I would be really worried about their connective tissue just because of their risk of things like spinal
Well, how about another
manifestations.
way of causing contractility? Using low-level electrical stim.
I like the electrical stimulation. The problem, of course, is that we know with certain spinal manifestations, it seems like that there's an electrical buildup in the cord, which is why a lot of patients feel like this internal tremor, or they actually feel like they feel sensitive to appliances. Have you had patients tell you that?
Sure.
So there are some interesting tidbits out there deep in the literature that only probably people like me read
And me.
that sort of show that when a cord is under tension, like it seems to it doesn't disperse. As you know, neural tissue, it's electrical. Most tissues are it's electrical transmission. But when a cord is under tension, there seems to be an electrical buildup. And I know that this sounds a little crazy, and it sounded crazy to me when I first read it. But the more I read into it and the more I understood it, it makes some physiologic sense. And so I worry sometimes about like electrical stimulation for patients with with a tethered cord or CCI, but if you don't have those diagnoses, I think those electrical stimulation devices are actually very good for peripheral muscles for sure. For like the large muscles in the
legs.
legs.
I'm sure you've heard, there are, at least on the internet world, people using EMF, pulsed EMF, et cetera, to deal with tethered cord and retethering, and with some benefit.
Right.
And PEMF can certainly help muscle and pain.
Yeah, no, I agree. I think that we need to understand more about the electrical nature of the body for me to know exactly how to use all those devices. And I agree with you. I have a lot of patients who use them who say that they get benefit from them. And I'm really excited about, any kind of neurobiomodulation, frankly, because I think that a lot can be accomplished. And I love anything, by the way, that's not a pharmaceutical. because it comes with its own side effects. But obviously, we know the benefits of some of them, and I use them regularly. But if I could also have an ancillary treatment plan that's non-pharmacologic, like a neurobiomodulation device, then I'm all about it. I just want to be sure that we're keeping patients safe, because I know about,
You don't want them shaking.
Right, exactly. Well, I do have patients, and I'm sure, I know that you do too, that really do report they can't be in a room when appliances are on.
Sure.
And because they feel like this sensitivity, as they describe it. And so that I just, again, I think every patient, I say this all the time, I really do think every patient is individual. And I take one of them at a time, and I learn about them and their story and figure out how best to help, as you do. So, but yeah, so that's, wow, we, as always, we went
all over the place.
And we'll continue to do that, because I love these conversations.
So we should definitely add in other exciting papers as episode
Yes.
topics.
Right. And when I sent you that article, I'm like, this is what we should be doing, because we
great
always
idea.
bring up articles
Just a
to each
great
other,
idea.
and we should allow that to be our focal point. And then if we want to jump off the page,
And if we ever learn how to do show notes,
we will.
we could
I know.
put it on
And
there.
I know. Our subscribers constantly ask for links to things, and I'm like, yeah, I wish I knew how to do that.
I can't believe it's so
I think we could obviously, we could put it on the Patreon page, a link to something, but it doesn't show up as a show note. It shows up as a reply to someone's message. But we'll figure it out.
Right.
I mean, that's not going to waste our time.
Yeah, I have no idea where we are at in time.
I don't know either. But we're going to
New
say
studio, so we don't have our person here to say time's up.
But this has been a real fun
Yeah, a lot of
conversation,
fun.
and reminds me of our early coffee clutch days.
Days,
But it was really nice for you to listen in on our conversation today. I hope that this was an enjoyable conversation and you were able to follow it and got some good tidbits. As you probably know by now, we regularly repeat things that are very exciting and fascinating and interesting to us, so you'll probably hear some of it again. But thanks for joining us, and we will see you next time.
Thank you.
Bye.